Good afternoon, and thank you and welcome back. I'm Gregg Meyer, the Chief Clinical Officer of Partners Healthcare, and thank all of you for coming and participating in Connected Health. I have a very special treat and honor this afternoon, and that is to be able to introduce my friend Dr. Ezekiel Emanuel. Ezekiel Emanuel is the Vice Provost for Global Initiatives and the Chair of the Department of Medical Ethics and Health Policy, and also the Levy University Professor at the Perelman School of Medicine at the University of Pennsylvania. Zeke went to undergraduate school at Amherst. He then got a master's degree at Oxford, where he was a Rhodes Scholar, and then came to the Harvard system, where he went to Harvard Medical School. And in addition to getting his MD, he also got a PhD in political philosophy. Since that time, Zeke's career has really spanned the worlds of clinical care, policy, politics, and philosophy. He spent some time as an oncologist at the Dana-Farber Cancer Center, where he was on staff, and then later went on to the NIH, where he was the founding chair of the Department of Bioethics there. He also has served as an advisor on health policy to the director of the Office of Management and Budget, and also to the National Economic Council, and played a very key role in the Affordable Care Act. Zeke's also a very prolific author. He's authored or co-authored more than 14 books. In addition to that, he has been very active in the popular press. He has written the Medical Directive, a comprehensive living will, which has been adopted by the New York Times, Wall Street Journal, and others. Many of you may have read Zeke's piece last year in The Atlantic, which is titled, "Why I Hope to Die at 75, which was quite provocative and got a lot of us thinking. Zeke is a member of the National Academy of Medicine. He also serves as the chair of the Meta Council for the Future of Health at the Global Economic Forum. I've had the pleasure of knowing Zeke for 22 years, since we served on Clinton healthcare reform together, and I have always found Zeke to be a provocative thinker. And Zeke this afternoon is going to spend some time telling us why he is a techno-skeptic. Please help me welcome Zeke Emanuel. Thank you.
Thank you, Greg. I'm here so Joe and Greg and the other organizers can say that the program is, in that famous Fox motto, fair and balanced. I'm the official designated techno-skeptic, and you always have to have one on a program like this. Otherwise, you guys might think you're in San Francisco. And the last thing we want to do is to have you confuse Boston and San Francisco. And I also noted that they have the techno-skeptic speaking right after lunch, so you're in your postprandial lull. Yeah, and being a techno-skeptic is certainly at a meeting like this quite lonely. We are, after all, in the United States. We're an optimistic people. You always have to speak in an uplifting way, be optimistic about the future. So I guess I'm here a little bit as that German accent on things. They like to have a downer at the end. So un-American. I do think, as a techno-skeptic, on the other hand, I have this unexpected satisfaction of being able to sort of feel, I guess, a little vindicated, maybe have a little credibility added to what I'm going to say. If I just say one word to you, Theranos. That kind of sums it up, I think. The example of a catchy idea, a lot of mystique, a lot of new technology, a valuation that makes it equivalent to the Quest and LabCorps of the world. Lots of big-name investors we've all heard. It's got a $9 billion market capitalization. That's in a segment of the healthcare industry that's worth $20 to $30 billion in annual revenues at most, where the margins are razor thin and the multiples are in the 1 to 1.5 fold, not the 7 to 10. I think there's a great case of techno hype coming down to earth. Now, some of you may say, well, that's not connected health. But Theranos will remind you about a lot of other things that might go under the name of techno health, or I mean of a connected health, the Google Vault, or was it Microsoft Vault, or whatever, one of those, electronic versions, the Google Glasses. And those of you who are, don't don't like techno-skepticism, I just think about Buckminster Fuller. If the name doesn't mean anything to you, go back and look at who he was and some of his brilliant ideas and where they ended up. And it's not for lack of brilliance. Of course, bashing is easy. There are lots of failed companies, failed ideas. So I just want to continue with it. I like the easy stuff. My good friend Eric Topol. I love the way Eric just struts on a stage, and he's holding up his iPhone and saying, look at this EKG on this iPhone, right? It's great. It's cool, right? It's a great Valentine's gift. You can also have the sound going simultaneously to your EKG. But how often do you actually need to see your EKG to know that your heart is still beating? And if you put it in a hat or on your wrist or around your chest in a piece of clothing, I'm not sure it makes it any more valuable at all or compelling as a connected health item. And I have to say, I also personally have some experience with connected health at a very low technology level. When I was in OMB, I was actually in charge of one of our projects. We sort of, as we're doing healthcare reform, wanted to send the message that we're interested in the health of Americans. And so we decided, well, we're going to give everyone in OMB, 550 employees that control the whole federal budget, we're going to give them a pedometer. And we're going to make a big deal of having people walk and looking. And we had a contest for teams and individuals. First day we handed out the pedometers. The head of OMB, Peter Orszag, walked from OMB to a farmer's market to show the whole complete picture. Walking, healthy food, blah, blah, blah. Few weeks, everyone stopped using them. And it's worth asking why, And I don't think the problem was that they weren't fancy pedometers with the Fitbit and all the other stuff you can see out there. I'm just not sure how often I need to know that I do 10,000 steps a day, plus or minus 250, except on the days that I go out running. There's lots of hype, lots of whiz-bang, and maybes, and imagine this. I love the ideas. I'm as taken with the new technology as the next person, but it's also, I think, important to be very skeptical about the whole continuum here. So I think if we think about all those wearables, the people who are doing quantified self and all the connections, not going anywhere, totally irrelevant to what we need to do. I think you can forget wearables for the masses, and we should not be lulled by early adopters in any one of the fields we're doing. These wearables and early adopter technology for connection, the users tend to be young, rich, healthy, easily connected, and you're not going to get anything out of them from a healthcare standpoint. Why is that? Well, let me just remind you about the simple facts of healthcare. Ill health or use of health resources is not spread evenly across a population like peanut butter, as healthy as peanut butter is. That's because 50% of the population uses less than 3% of all healthcare resources. They're really out of the system, recording their heartbeats, recording how many steps they take, recording how well they sleep is not going to make hell or beans worth of difference to the healthcare system, and I don't think there's a whole lot of money there. Investing in them is not going to pay off now. If you look at Oscar, that health insurance company in New York, giving out the misfit item to their people, it may be good to engage people. They pay them $1 to get steps per day. They pay them $1 a day. It's a very expensive engagement mechanism if they actually reach their level every day. It might work well just to have healthy people engaged, want to renew with you, and therefore be good for your risk selection of your insured population. Although $365 a year or even $300 a year is a lot to pay to keep people signing up. But I think the big issue is, what's it going to do in the whole flow of the healthcare system? So as a techno-skeptic, here's what I would suggest. We have to think about all the connections and how they might successfully work in the system. So the first thing I would say is you got to target, and you got to target right. Remember, top 10% of spenders spend about 65 to 70% of all healthcare dollars. And remember who they are. They're people with chronic illness, congestive heart failure, COPD, diabetes, asthma, cancer, hypertension, depression. They're older. Young people aren't sick that much. Old people are sick. So they're not so tech savvy. They need stupid, invisible devices that stay behind the scenes, and they don't have to do too much. They don't have to be engaged in the same way. Also remember, they're relatively poor or low income, and spending money is going to be a problem for them. The ROI is mostly for these people going to come in avoiding the hospital, avoiding institutional care, avoiding the healthcare system. And you're going to work, or being connected is only going to work by keeping them healthy, out of the hospital, or not coming back to the hospital if they've been. That's one way. Another way is if they have to be treated, being able to treat them more easily, again, out of the hospital, in their homes at a cheaper site. Now, with all my techno-skepticism, I think there is a lot of stuff that can happen in the connected health sphere that makes this work. I think we can have good technologies. I know that there are several companies out there about drug compliance. Not all of them are going to succeed or be adopted. I also like the idea of having a connected company that actually peels away medicines, because most people we know have too many medicines, and we can safely peel away more than half of their medicines, especially older people, where they feel better and might be more compliant. I think there's big space in the mental health sphere. Videos in homes so that you can actually monitor people, although the invasiveness, I think, we're going to have to work out. And then easy-to-use items for crises. My favorite example is caring for patients at the end of life who've agreed that they don't want to be re-hospitalized, that they want to be at home, their DNR, and then something bad happens at home. And the first thing that a family member does is dial 911 and start the cascade where no one can get off the trip to the emergency room, maybe even the ICU, even though no one wanted it. And so you need some intervention that people can dial other than 911. So as we think about how connected health might work with the healthcare system, I think we need to think about the steps. For me, there are 7 steps between the technology and actually the end result, maybe 8 steps. First, you obviously have to engage in some way, even if it's only to install the connection. You need to get data from people. You need to have that data transmitted reliably. You need to use the data inside a healthcare system or inside somebody. Fifth, that information needs to be used to have sustained behavior change. And that's a key issue. That behavior change actually has to lead to a health improvement, not just sustained behavior change. And that has to lead to saving money so someone will actually adopt it. Each of those steps has a huge challenge. And I don't think you're going to have a successful adoption without that. Just to think of one, the adoption saving money means you're going to be taking it from someone. And if that someone is very big, they may not want to do that. So I was just talking to Gregg. Partners is interested in adopting a lot of technologies that will reduce its hospitalization because it's going at risk, and it's been dinged for readmissions. So they may be very interested in adopting technologies that will avoid readmission, and actually it might be in their financial interest. On the other hand, there are very big hospital and health systems. I can think of two, New York Presbyterian and my own system at the University of Pennsylvania. We're not interested in risk. We're interested in riding the fee-for-service pony as long as we can. We're not going to pay for that stuff to keep them out of the hospital, or that's just not interesting to us because we don't make money that way. You might think of us as the bear in the path. You're taking our money. I'm not so interested in that connected health thing you got. Now, data is great, but it's not useful information, as we all know. And it's got to go into an electronic system, and it's got to be connected to someone to make it useful. And I am quite skeptical how fast that kind of connection is going to happen and how quickly. Given the state of our electronic health records, the state of interoperability, the easy electronic integration of your connected data into a system that can get that information analyzed and in front of a decision maker and someone who can actually push a button and have something happen, complicated, and the more it has to come into a central hub like a health system, the more difficult it is. If there's no receptor for the data, not going to happen. And even if there is a receptor for the data, it has to go on a reasonable timeline. And most of us have had experience with these health systems that reasonable timeline and their timeline may not be the same thing. It also has to integrate into the workflow of the health system or the physician's office or something. We've had a lot of great ideas that don't well integrate into workflow and don't get adopted because it requires substantial changing by physicians or their office, and that change in workflow is very hard, especially for physician offices. And the last, and I would say most important thing, is having information, having it go back and so it's useful, isn't going to cut it either. Just getting the data and having the platform. The real issue is we need a change in that can be implemented. What's the effector arm? Collecting my heart rate, I need an effector arm. Or actually, for me, one of the great inventions that I heard about is this ability to determine whether I'm depressed or not just by a few words that I speak or the way I type on my computer or respond on my iPhone. That's fantastic. You can tell with high accuracy, better than if I take one of those surveys, whether I'm depressed or not. But that information off the phone needs to go into the chart. It needs to be noticed. It needs to get into the flow. And then you need an intervention for treating my depression, which is very hard. And it has to work in someone's interest to actually treat my depression. And that's not going to be readily obvious, I think, to a large part of the system, that that's actually going to be quite valuable for another 5 or 7 years. That integration, that effector arm, having something that you can use to get sustained behavioral change that'll improve health, that'll save money, I think that's the big problem. And it's not clear to me that the connected health part actually helps massively with that. That's not to say there aren't going to be lots of these new inventions and ideas and electronic toys that are going to make a big difference. I do think something on drug compliance will become state-of-the-art and standard. I do think many things in the telemedicine space so that people actually intersect with someone and don't go to the emergency room are going to be good. But going from gadget to health improvement to healthcare cost savings is hard. As I mentioned, it's a 7-step process, and each one of those steps are fraught with problems. There's that bear in the path whose money you're taking who may not agree it's such a hot idea to put this new technology in. There may be no receptor in the healthcare system for getting that data and converting it into useful information. Doesn't work in the workflow, probably not going to actually be adopted, sit on the shelf and collect dust. And if you don't have an effector that leads to sustained behavioral change and actually improvement in health, I'm not so sure. So I'm pretty glad I could help Joe, Gregg, and the other organizers to be that fair and balanced element, be the GPS of the conference, to bring the German element here. But it is great to have you thinking of new ideas, thinking of new inventions, and for me to be the skeptic, to keep you honest about your new interventions, that just having patient engagement or some other great data collection platform is insufficient and will not transform healthcare. I thank you very much for your attention. I'll remind you that I'm signing books outside about how to reinvent the American healthcare system and why we really do need to focus on the chronically ill, but that we are actually going to solve some of our problems and make the system better. Thank you very much, and enjoy the conference.